Boa tarde a todos. Em nome da Associação Brasileira de Hematologia e Hemoterapia, ABHH, agradecemos a presença de todos e o apoio da EMS nessa importante iniciativa de hoje. Meu nome é Fernando Costa, eu sou professor de hematologia da Faculdade de Ciências Médicas da Unicamp e coordenador do Comitê de Glóbulos Vermelhos e do Ferro da ABHH. Hoje nós teremos o prazer de assistir a uma importante discussão sobre a experiência do Brasil e da França no tratamento dos pacientes com doenças falciformes acometidos com Covid-19. Um assunto muito importante para todos nós. Eu quero dizer que as perguntas poderão ser feitas pelo bate-papo e, ao final de todas as aulas, elas serão respondidas. A primeira apresentação, nós vamos ter a honra e o prazer de assistir à apresentação do professor Jacques Elion, que é professor de Genética Molecular da Universidade de Paris e professor visitante da Universidade de São Paulo, da Faculdade de Medicina de Ribeirão Preto. O Dr. Jacques vai falar sobre a experiência da França com pacientes com doença falciforme acometidos com Covid-19. Sr. Jacques, grande amigo, é um prazer tê-lo aqui.
É um prazer. Porque I cannot speak Portuguese, but thank you very much for this very kind introduction. Well, good afternoon, everybody. I'm very glad to participate to this webinar where we will share the experience of France and Brazil in the treatment of sickle cell disease patients affected with COVID-19. I should say also it is a great honor for me to show you the experience of France. So actually France is part of the European Union, and which is a group of 28 countries. The total population is 445 million. And within this European Union, France has a population of 6 million. Now, if one look at Brazil, you can see on the superimposed map of Brazil that Brazil is much more larger than whole Europe itself, and of course of France. And you are not the one to whom I will say that Brazil has a population of 212 million. But this was to put the things in perspectives. Now, the European Union has also what is called the outermost regions. And these are somewhat important because some of them are areas with a very high prevalence of sickle cell disease. For instance, the French Antilles, here the islands of Guadeloupe and Martinique, and the French Guyana, who has a common border with Brazil, are French regions with very high density of patients with sickle cell disease. Also in the Indian Ocean, there are two islands, the island of La Réunion here and the island of Mayotte, where sickle cell patients are very present. Now, sickle cell in France has the highest absolute number of patients in Europe. It is estimated to be 22,000 patients. This figure is a little higher, but quite comparable to the situation in the United Kingdom. Sickle cell disease is the most frequent genetic disease in France, and there is a national newborn screening program. The global incidence of new cases every year is 1 out of 1,700 births, and but it is higher in large megapolises like Paris, where about 1 newborn out of 700 is affected, and of course in the French Antilles and French Guyana, where the incidence is about 1 over 250 new births. Now, France has a national program for rare diseases, this program has organized a very dense network of 13 sickle cell disease reference centers and 46 competence centers, supervised by 2 coordinating centers, one being located in Paris and the other one in the island of Guadeloupe. We call them filières de soins et de santé. There is a very strong connection with the general practitioners and patients associations. And also there is a strong connection with clinical and basic research, in particular with the Laboratory of Excellence on the Red Cell, called GREX. Now, French health system provides free access to care. This is what we call the sécurité sociale, social security. Also, hematology is organized at the European level because there is a network which is funded by the European Union, and for hematology and including sickle cell disease, this network and coordination is called EuroBloodNet. Now, if we turn to the COVID pandemics, I'm showing you this map that you have all in mind. I think to date we have to deplore more than 700,000 deaths worldwide. And you know that the sequence of the epidemic started in China, then was very predominant in Europe. And now the disease and the viruses are expanding in North America and South America and Brazil in particular. If we look at the number of deaths worldwide according to time, you see that there is almost a plateau here, and whereas the situation is very different in France and in Brazil. In France, the peak of the pandemic was in April, and as you can see, the contamination now is reduced to almost nothing. Also, although with the vacation period here, we are seeing an increase in the infections, and we are fearing a second wave of the pandemic. The situation in Brazil is different because the pandemic was delayed as compared to France, and up to now, from this data that I took from the Johns Hopkins University in the US, show that there is a plateau and no decrease yet of the pandemic. This curves here are just to illustrate the mortality, over-mortality that has been observed in France. Here you have the curves of mortality over the 20 past years, and here in red the curve of mortality in France this year, 2020. What you can see also here is, and what is important, is the number of deaths per million people. You see that Belgium, a very small European country, has been the most affected because it has more than 800 deaths per million inhabitants. And Brazil here is ninth from the last figures I have, right before France, with more than 400 deaths per million. I know that the total number of Brazil is over 100,000, and in France, the total number of deaths is 30,000. So now, as sickle cell disease and COVID pandemics, when the epidemic started in France, our priority was really to keep the patients confined and to prevent them to come to the hospital. Actually, the full lockdown was started in France March 15 and ended May 10th. And then there were progressive lockdown uplift with several phases, and this uplift is still going on with some restrictions and the fact of wearing masks and all these preventive measures. So what we wanted for our patients, once again, was to keep the patients confined and prevent them to come to the hospital. So on May 15, all the programmed consultations and at the reference centers were canceled, and information was provided by phone to the patients, by phone consultation. And during this phone consultation, instructions about lockdown were repeated, and it was told to the patient to stay at home, to do teleworking, or ask for sick leave from their employers, to respect social distancing and the prevention barriers. Sorry. But it was also said to the patients to continue their treatment, avoiding AINS. Repeated information on COVID infection, warning signs, and or sickle cell disease related signs were also given. And also this phone consultation was very important to listen to the patient and building confidence, because a lot of patients were very, very anxious about the situation. So the step we took to ensure a proper functioning of this system was to set up a telephone platform that was accessible from 9 a.m. to 6 p.m. on weekday. And also we asked voluntary colleagues to be on call on weekends. Dissemination of the information was also done by the Patients Association, who played a very important role in this whole procedures. And also we established a leaflet for recommendation for the patients that was available either from the Patients Associations or from our centers for sickle cell disease. Now, if we think about sickle cell disease and COVID pandemics, we are thinking mainly about two major complications: the vaso-occlusive crisis, and also the evolution with of this crisis toward the acute chest syndrome, which, as you all know, is a very severe complication of sickle cell disease and can be a fatal complication. So our priority actually was to shorten the stay of the patient at the emergency room as much as possible. And to do that, you have to be able to discriminate between patients at very low risk of acute chest syndrome for those at high risk. So for adults, we took a predictive score, which I'm going to describe now, which is called the PRESERVE score, and which was established by Pablo Bartolucci, the first author of the article. It is a French work. So this is how the PRESERVE score goes. First, it established a scale of pain, you know, from 0 to 3, from no pain to very severe pain, and also distinguishing the location of pain. Pain in the spine and pain in the pelvis were considered to be the more significant pain to take into account in calculating the score. So the score relies on the pain of spine or pelvis. It relies also on reticulocytes number and on leukocytes count. And so you can calculate a score which varies from 0 to 5. And distinguish very high risk patients with severe pain affecting the spine or the pelvis, with the reticulocyte count higher than 216, and the leukocyte count to higher than 11. But the most important thing about this study and establishing this score is the predictive negative value of a score lower than 5. Because if a score is lower than 5, there is a 95.5% of chance that the patient will not develop acute chest syndrome. So we used this preserve score in our strategy. So for the patients who came to the emergency room, actually, we could identify 3 main possibilities. The first one was to measure a preserve score below 5 and state that the patient was not at risk of developing acute chest syndrome. So this patient was discharged, but there was home hospitalization. We have a very strong system for home hospitalization in France, and home hospitalization for these patients meant 2 to 3 nursing visits per week, during which vital constant surveillance was performed, sensitization to the complication of COVID infection and sickle cell disease was given. There was also during this week 1 call consultation by telephone to the doctors at the centers, and it was made sure that the patient could use oral morphine with a very detailed protocol, that these patients were hydrated subcutaneously or intravenously, that they were able to use nifopam intravenously, enoxaparin, an anticoagulant at low dose, was added to this protocol. Availability of oxygen, if necessary, was checked, and also the patients had to give 1 call to the tele platform during the weekend, and the patients who were not calling, then the voluntary colleagues at the platform would call them. The second possibility was if the preserve score was higher than 5, so that there was a risk of developing a acute chest syndrome, then of course this was taken care at the hospital, but the time of hospitalization was kept as short as possible. And then the patient was discharged when the situation was stabilized, and the same home hospitalization protocol I just described was utilized for these patients. Then the third possibility, of course, was that the patient was infected with COVID. And so for this patient, we applied an outpatient COVID protocol that we called COVISIC, and which was based also on home hospitalization with 2 to 3 nursing visits per week, with an antiviral drug that was left to the choice of the clinician, with antibiotics, measurement of the vital constants, sensitizations about the COVID complications and sickle cell disease complications in relation to COVID infection. One call consultation per week also was ensured with the doctors, and one call during the weekend was performed by the voluntary colleagues at the phone platform. And I outlined here a fourth situation, which is that the very often anxious patients on the phone called. So when they called and they were anxious, there was daily telephone monitoring, but no nursing visits planned. So this score that I just described has not been validated for children, pediatric patients, and for all the pediatric patients that were hospitalized at the intensive care units. What we use is intravenous fluid, prophylactic enoxaparin for all antibiotics, which were cefotaxime or azithromycin, antiviral therapy, which was also left to the physician choice, analgesics, except non-steroidal anti-inflammatory drugs, hydroxyurea or deferrazirox was continued, except in case of drug toxicity. Early non-invasive ventilation was used for respiratory distress, oxygen for hypoxemic patients, and red blood cell transfusion or automated exchange transfusion was done when the physicians thought it was necessary. CT scans were not mandatory. Nasal swab for RT-PCR testing for COVID were collected in the first 12 hours and of the patient's arrival. So we established also a French registry of the hospitalized patients for COVID-19, and the results of this cohort was recently published in the Lancet Hematology. It was conducted from March 13 to April 16, and 83 patients were infected by COVID, were enrolled in 24 centers. 85% of the patients were SS or S-beta 0 tau, 10% SC, and 5% S-beta plus tau. The median age was 33.5 years, ranging from 19 to 68 for the adults, and 12 years, ranging from 0.3 years to 17 years for the children. We found that in this cohort, vaso-occlusive crisis was associated with COVID-19 in 45% of the cases, and acute chest syndrome in 85% of the patients. 20% of the patients globally were admitted in intensive care unit. This is a table of the results of this paper, and the most important and interesting aspect is the complication. This is the death according to the age range, and what we can see is that we observed only 2 deaths that were in the age range of the patients between 45 and 64, and the interesting observation is that the number of deaths, so we observed none in the age range from 15 to 44, that is lower, significantly lower than the death rate observed in the general population. So this result suggests that COVID-19, even if potentially severe, does not seem to carry an increased risk of morbidity or mortality in patients with sickle cell disease. The risk of mortality even seems lower in the 15 to 44 age range than in the general population. We don't know exactly the reason for that. Could it be that the sickle cell population is in closer contact with the doctors and with more attentive to its health condition? It could be also that there is a protective effect of sickle cell disease, in particular of the S-beta 0 tau genotype. But this remains, of course, to be investigated. So the conclusions, which of course can be only preliminary at this stage, are three important words that are reactivity, vigilance, coordination, coordinations of the health workers. The setup of the telephone platform was the major point in the surveillance and the taking care of our patients, in particular this on-call weekend platform. The transverse experience of seniors in the reference centers also was a very strong asset for the whole system. Strong home hospitalization system also is very important in our own strategy. Expert and coordinated bibliographic and surveillance are important aspects as well. And patient adherence to the defined protocol is very important. And we were very happy to see that there was a very positive appreciation of the patients of the global follow-up at home. The results that we have are reassuring for the moment in terms of morbidity and mortality, but vigilance is required in particular for sickle cell patients. Merci. Thank you.